This conference will now be recorded.
Hello everyone, good evening. You are welcome. Today, inshallah, we'll discuss about the Intrapartum Care NICE Guideline 2019. And this is a very, very important guideline and modules because in exams, there's a lot of question, especially AMQ, came in exam, especially from this guideline. So today, inshallah, we'll focus in on the Intrapartum Care NICE Guideline. And inshallah, the next session will be about the management of labor. And inshallah, we'll cover it. Okay, let us start our lecture. This chart shows the place of pairs in UK. According to NICE Guideline 2019, there are 4 places of pairs. First is the home pairs alongside midwifery units and freestanding midwifery units and obstetric units. So this is the 4 major places of pairs in according to the NICE Guideline Intrapartum Care 2019. What is the difference between alongside midwifery and freestanding midwifery? Anybody knows? What is the difference between alongside midwifery and freestanding midwifery? Is there any difference?
Alongside means alone, but midwifery freestanding, it's included in a hospital unit. So if any emergency, it's going to be shifted to obstetric unit.
Yes, you're right. Yeah, alongside midwifery units, that is mean it is in community setting. So maybe far away from the hospital, and freestanding should be close to the obstetric units. So should be beside and close into the obstetric unit. That is the difference between alongside midwifery units and freestanding midwifery units. So the freestanding midwifery units provide care to healthy women with straightforward pregnancy during labor and following pairs. So this is for straightforward pregnant woman or low-risk woman. And freestanding are set in the community settings, often in community hospital, which on the had specialist obstetric units. So, but alongside midwifery units are located close to the obstetric units. So this is the difference between alongside and freestanding midwifery. Next. Here, this chart shows is the difference between home births and freestanding midwifery units, and alongside midwifery units and obstetric units. So in home pairs, here the difference, the rate of intervention is very low, and there's high rate of spontaneous vaginal pairs, and associated with a small increase. It's about 4 more per 1,000 pairs in the risk of baby having a serious medical problem compared with the other setting. So this is regarding the home births, and there is low intervention and high rate of spontaneous vaginal pairs, and associated with 4 or more per 1,000. And the freestanding, as before we said, this is the community setting. Here, the high rate of spontaneous vaginal pairs than planning pairs in the obstetric alongside midwifery units. So there's high rate of spontaneous and high rate of spontaneous vaginal pairs than planning pairs in obstetric units. And alongside midwifery units, which you said before, this is beside or close to the obstetric units, and maybe in the same building, and there is no difference in outcome for baby associated with the planning birth in alongside midwifery units, a freestanding midwifery or obstetric units. And in obstetric units, there is high rate of intervention as intraobstetrical canal birth or cesarean section, and associated with the small increase for more per 1,000 in the risk of the baby having serious medical problem compared with other settings. This is generally about the difference between home births and freestanding midwifery and alongside midwifery and obstetric units regarding the spontaneous vaginal births and intervention and about the rate of spontaneous vaginal birth. So we'll discuss later in each tables. Yes, in this table, there's important information about the rate of spontaneous vaginal birth transferred to the obstetric units and obstetric intervention for each planned place of birth in low risk multiparous woman. This is very important in low risk multiparous woman. So this chart shows the spontaneous vaginal birth at home is higher than freestanding midwifery units alongside an obstetric units. So here, spontaneous vaginal birth is higher in home rather than the other settings. And regarding the transfer to the obstetric units, there is highest in home and also in long-standing and less than in the freestanding midwifery units. And definitely here is very low in obstetric units. And what about the use of regional analgesia, like epidural and or spinal anesthesia? Here at home is very low, and here is higher in obstetric units. And there's other intervention. We said before it is high in obstetric units as episiotomy, cesarean birth, and instrumental vaginal delivery. This is about the rate of spontaneous vaginal birth in case of low risk multiparous woman. So what about the outcome of for the baby for the each planned place of birth in low risk multiparous woman? So we'll show the outcome for the baby in low risk multiparous woman. So here we'll divide in two groups: babies without serious medical problem, and babies with a serious medical problem. So here there is no difference between the four settings for birth in home or the freestanding midwifery or alongside midwifery or obstetric unit is the same. Here is the same finding. And if the baby also is with the serious medical problem, here the outcome here is the same. So it's no difference in case of long risk multiparous woman. The same here if the baby with serious medical problem or without serious medical problem. And what about the rate of spontaneous vaginal birth transferred to the obstetric units in low risk nulliparous? Before we discuss the multiparous woman, now we'll discuss about the difference in spontaneous vaginal birth regarding low risk nulliparous woman. So here also spontaneous vaginal birth is higher rate in home as the multiparous woman. Okay, here is no difference. Here is the same. And look for the outcome for the baby in low risk nulliparous woman. Sorry. Here, really we're focusing about the area of the question or the recall question. Okay, here this table shows the outcome for the baby for each planned place of birth in low risk nulliparous woman. Before we discuss the risk in low risk multiparous woman with the same, if the baby is serious medical problem or the babies without serious medical problem, it's the same in the four setting. But here there's difference. Here in the babies without serious medical problem, here is the same in nulliparous woman and into the multiparous woman. Here is no difference. It's the same in four setting. But here in nulliparous woman and low risk nulliparous woman, the babies with the serious medical problem, there is high rate of baby is about 9 per 1,000. This is higher than in obstetric units or alongside or the freestanding. This is the recall question. It's about the babies with the serious medical problem. So there is high problem associated with the fetus deliveries in the home setting. So here is the difference between the home and the other three settings. Is it clear?
Yeah, clear.
Okay.
Yes, sir. Clear, sir.
Okay, table 5. This is also record question. Here about the primary reason for transfer to the obstetric units. For this 4 setting, home, 3 setting for home, and from the freestanding, and from alongside midovarian. So, what is the commonest cause for transfer the patient to the obstetric unit is definitely from the home, and the cause is the delay during phase or second stage of labor. This is the recall question. Ask about the primary reason for transfer to the obstetric unit. In home is about 1,144. It's about 32.4%. And this is the recall question. If you ask you about what was the primary reason for the transfers to obstetric unit from the home, it is the answer. It is delay during the first or second stage of labor. This is the recall. There's other causes, but the commonest one is the delay during first or second stage of labor. Now we discuss about the labor. What about the stage of labor? As you know, basically you know, there's 3 stages of labor: the first stage, and the second stage, and the third stage. And the first stage is the stage of cervical dilatation, and the second stage is the delivery of the fetus, and the third stage is the delivery of the placenta. Okay, so we'll discuss it separately. What is the 2 phase of the first stage of labor? What everybody knows? What is the 2 phase of first stage of labor?
The passive and the active stage.
Yes, this.
No, latent and active phase.
Latent first stage or established first stage. Agree? You have 2 stages: latent stage and established stage. So this is the 2 stage of the first stage of labor. What is the definition of latent first stage? What is meant by latent first stage?
When there is cervical dilatation less than 3 centimeter and irregular uterine contractions.
Yes, excellent. Yes, and this is the stage of cervical effacement and dilatation up to 4 centimeter. This is the first. This is the first stage. Okay, latent first stage. What about the established first stage?
From 4 centimeter till full dilatation of cervix.
Yes, thank you, Hannah. Yes, it is. This is the stage of progressive cervical dilatation from the 4 centimeter up to full dilatation. Yes, here, this is the first stage of labor, and the Latin first stage of labor is cervical effacement and dilatation up to 4 centimeters. And the second one is established first stage of labor, and there is progressive cervical dilatation from 4 centimeters up to fully dilatation. So what about the initial assessment? So initial assessment here is very important. The main aim of the initial assessment of the woman in the labor here to define the risk of the patient. Is it this patient is high risk or this is the patient low risk? Because the follow-up during first stage of labor, it depends on the classification of the patient. Is it this patient low risk or high risk? So you should take history to focusing about the risk factor in this patient. Okay, and then do examination to know about the lies, the position. You should do vaginal examination and fetal heart rate, and this woman is established labor or in the Latin phase. This is very important in the first assessment of the patient, and to decide to give her analgesia. What about the analgesia in labor? What about the analgesia? Anybody have idea?
Epidural is ideal.
Anybody knows about the Intrapartum?
It's epidural anesthesia and Enternox, then this morphine, dimorphine, Patharin, fentanyl, patient control and analgesia like that.
Yes, thank you, Dr. Hannah. This analgesia is important here to give the patient Enternox in the most used analgesia in the labor, which is about 50% oxygen and the 50% is nitrogen oxide. So this is about the analgesia in labor, and we'll discuss it later, inshallah. This chart shows about how to follow the patient in the first stage and second stage regarding the fetal heart rate, uterine contraction, PV, and maternal pulse, and this maternal blood pressure and maternal temperature. So in the fetal heart rate, this is as a recall question. In the first stage is every 15 minutes low risk. This is the every 15 minutes. And the intermittent auscultation here in the second stage is about every 5 minutes. So here, this fetal heart rate in low risk common. Intermittent auscultation is every 15 minutes in the first stage of labor and every 5 minutes in the second stage. And uterine contraction should be checked every 30 minutes. And PV here, the routine is every 4 hours. Yeah, in the first stage of labor and every 1 hour in the second stage of labor. So PV here is very important to know about the regulator of the PV in the first stage of labor should be every 4 hours, and the second stage 1 hour. And maternal pulse should be checked is the same. The first and second stage is every 1 hour, and maternal blood pressure is about 4 hours in first stage and hourly in second stage of labor. And maternal temperature is the same, as should be checked every 4 hours in both first stage and second stage of it. This is about the vital sign and the fetal heart rate and BV, and in case of patient in first stage of labor and the second stage of labor. This is BV is the EMQ question, and maternal blood pressure. This is the SPA and EMQ also question, asking about the maternal blood routine measurement of the blood pressure during the second stage. It is checked hourly. And in the first stage, it should be checked in 4 hours. This is very important. What about the fetal heart rate assessment and the reason for transfer to continuous electronic fetal monitoring? At what time we shifted the patient from the intermittent auscultation to the continuous electronic fetal monitoring? So intermittent auscultation for the low risk woman in established labor. As you know, in this intermittent auscultation, only for the low risk. The high risk woman, we should monitor it by the CTG. Once in established labor, intermittent auscultation of the fetal heart after contraction. So we'll measure the fetal heart rate after the contraction. If there's any change from the intermittent auscultation to continuous electronic fetal monitor in the low risk woman, in special cases, if one of this is occurred, we'll shift from the intermittent auscultation to the continuous electronic meter in case of significant meconium. If there's any significant meconium, you should transfer from the intermittent auscultation to the continuous electronic fetal monitoring. And if there's abnormal fetal heart rate on intermittent auscultation, and if there's maternal pyrexia, so if there's maternal pyrexia and there's fresh bleeding in labor, oxytocin used for augmentation, and if the woman is requested. This is the causes. If there is any one of this, you should transfer the woman from the intermittent auscultation to the continuous electronic fetal monitoring. Is it clear? Okay, what about the possible routine intervention in the first stage? Okay. Do not routinely overactive management of labor. This is the not routine, one-to-one continuous support, strict definition of established labor, early routine amniotomy, routine 2-hour vaginal examination, and oxytocin if labor becomes slow. In normally progressing labor, do not perform amniotomy routinely. So in case of normal labor, avoid to do active management and to do amniotomy and to give the patient oxytocin. Here, this is very important here because now we discuss about the how to suspect the delay and how to confirm the delay. This is a very important in this guideline because there is many questions in SPA and MQ came in exam asking about at what time we do BV and how to do suspect and how to confirm a delay. So as before we said, BV in the first stage of labor should be done 4 hourly. So if there's any delay in the established first stage of labor, consider all the spectrum of labor. Cervical dilatation of less than 2 centimeters in 4 hours for the first labor. If the patient, if you do BV in 4 hours, every 4 hours, you find the cervical dilatation less than 2 centimeters, this is suspect, there is maybe suspect delay. There's suspected delay. And after that, how to confirm the delay? You should do BV after 2 hours. Okay? If you find less than 1 centimeter, this is the confirm there is delay in the first stage of labor. Okay? So first, you suspect the delay if you find cervical dilatation of less than 2 centimeters in 4 hours for the first labor. And cervical dilatation of less than 2 centimeters in 4 hours or slowing in progressive of labor for the second or subsequent labor. So how to confirm? We said we'll do BV after 2 hours. If you find less than 1 centimeter in 2 hours, this is the confirm there is delay in the first stage of labor. If you find after 2 hours, repeat BV after 2 hours, we find more than 1 centimeter, this is the normally progress. Is it clear? Is it clear
yes,
about
doctor,
how?
it's very clear. Yeah, it's clear.
Yes, very important here to differentiate between how to suspect and how to confirm. BV in suspected delay, after 4 hours, you're looking for cervical dilatation. If less than 2 centimeters, it is suspected delay. After that, you should do BV 2 hours. If there is less than 1 centimeter, this is confirmed there is delay in the first stage of labor. After that, if you confirm there is delay, you should consider parity, cervical dilatation, and the range of change, uterine contraction, station and position of presentive part. So you should consider amniotomy. So you counsel the patient about the amniotomy. And the amniotomy can decrease the labor by 1 hour, and the can make the contraction more power, and perform vaginal examination 2 hours later. If progression less than 1 centimeter, make a diagnosis of the delay. This is about how to know about the suspected delay and to confirm delay. Generally, if you do examination BV, if you have the case or the scenario, give your patient BV 4 hours. If you find this is 2 centimeter, we'll do BV after 2 hours. So it is suspected delay. So you should consider amniotomy if the membrane is intact. After that, we'll do 2 hours. If you find 1 centimeter, this is the confirm there is delay. And after that, then looking for the parity. Here, the parity is very important. Is the patient nulliparous or the patient multiparous? If the patient nulliparous, you can consider oxytocin. If the patient is the multiparous, you need to do assessment of the patient first before to give her oxytocin. Don't give her immediate oxytocin. You should examine the patient, reassess the patient to know what is the problem, and then we decide to give her oxytocin or to do cesarean section. It depends on the condition. Okay. Here, if you confirm delay, look for the parity. If nulliparous woman, consider oxytocin. If there's multiparous, you should do full assessment before making decision about the use of oxytocin. And very important, if they give the patient oxytocin, you should do vaginal examination 4 hourly. This is very important. In case of patient on oxytocin, you should do vaginal examination 4 hourly after commencing oxytocin in established labor. So not for 2 hours. If you give the patient oxytocin, you do vaginal examination 4 hourly. Here about how to, here we'll summarize how to suspect the delay and how to confirm the delay. So if you do BV in 4 hourly and you find this is about 2 centimeter, okay? If you do BV and found it's about 4 hours, about less than 2, they suspected delay. Okay, then we look for the membrane is intact or not. You should consider amniotomy and you do BV in 2 hours. You should cancel the mother of the amniotomy. It can reduce the labor by 1 hour, shorten the labor by 1 hour, and you can tell her about this can stretch and increase the power of the contraction, and do BV in 2 hours. So if you find the BV more than 1 centimeter, less than 1 centimeter, you should look for the parity. This is diagnose the delay. Here, this is the diagnosis delay, because you do BV in 2 hours, or less the BV less than 1 centimeter. So we look for the nulliparous parity or the patient is. Here, if the patient nulliparous, will consider oxytocin. Okay, And then you can reassess after 4 hours. Because the patient already on oxytocin, you should reassess in 4 hours. In case of multiparous, first you should do full assessment to exclude this of obstructed labor, this any abnormalities. And before that, after that, if you want to decide to give her oxytocin or not, and you need to do assessment after 4 hours. If you give her oxytocin, after 4 hours, if you find this stills be less than 2 centimeters in both nulliparous and multiparous, you should consider cesarean. Even this B or the BV more than 2 centimeters after 4 assessment after oxytocin is equal or more than 2 centimeters, you need to go to the routine BV to assess in 4 hours. So this is about how to deal with the patient with suspected delay and confirmed delay. Is it clear?
Dr. Fat, I have a doubt, please. When we
Yes.
do a PV in 4 hours and it is less than 2 centimeters dilated, we suspect a delay. Okay. And in the previous slide, you told that then we will repeat the PV in 2 hours. And if it is less than 1 centimeter, then it is a diagnosed delay, and then we consider an amniotomy. Or we directly consider amniotomy in suspected delay.
Please again.
Like
is the first here is this
we in this
after
we
first
repeat the
BV.
PV. Yes, then we have to repeat it in 2 hours. If it is less than 1 centimeter dilated, it is a confirmed
Yes,
delay.
because already here we'll cancel the patient hours of amniotomy, and if the membrane
No.
intact, will do membrane rupture.
Okay,
So a BV
we will
in
not
2 hours.
Okay, so that means we will not like confirm the delay by repeating the PV in 2 hours. And if it is less than 1 centimeter, then do amniotomy. Like
Yes,
in the
first okay, let me to explain. Okay,
in the
first
previous
we'll do
slide, Dr. Sir. In the previous
yes, first
slide,
we'll
it was
do
like
2 hours. Okay, we'll do
yes,
amniotomy here. You if you do they suspected in routine,
yes,
if you have do BV in patient, and after 4 hours you find there's less than 2 centimeters. Here is the suspected delay. Here first, this is suspected delay. Here, this is the suspected delay. Because you do BV and you find less than 2 centimeters. If you find equal or more than centimeters, this is not delay. This is
yes,
the normal. So
yes,
first start with the patient suspected delay.
yes.
You should
And that
do 2 things: amniotomy and BV after 2 hours. Here, we'll do amniotomy and BV after 2 hours. Is it clear?
Dr. Pat, in the previous
Okay.
slide, in the previous slide, we mentioned that we will confirm delay by PV in 2 hours, less than
Yes.
1 centimeter, and
Yes.
then do
Here,
amniotomy.
look for this. Here, about 1 centimeter and above. Okay, that is the normal. We'll do after 4 hours. But after suspected, you find the BV less than 1 centimeter. This is the diagnosis delay.
Okay, thank
So
you.
we look for the paradigm. So we do BV 2 times. In 4 hours, we find less than 2 centimeters. Then do amniotomy and BV in 2 hours. Okay. After that, we look for the patient is the multiparous or nulliparous. So you should consider oxytocin and reassess in 4 hours. And in multiparous, you look for the assessment, first assessment of the patient, and you can give oxytocin. If it's still there is less than 2 centimeters, you should consider cesarean section. And if about 2 centimeters or more, you should go to routine BV. every 4 hours. You got my point?
Yes, thank you, sir.
Okay. Yeah, we'll look for this. Here is the same chart. Okay. I will discuss it again. Okay. Look for this chart. Here, this suspected delay, and you do BV, and you found this 2 centimeter. Here, the nullibras is about less than 2 centimeter in 4 hours. In routine BV, you find this less than 2 centimeter and dilatation in 4 hours. And in para study also is this less than 2 centimeter in 4 hours. So they suspected delay. Here is suspected delay. Also here is suspected delay because in 4 hours we find less than 2 centimeter. What is the next step? Here is to consider ammoniotomy.
Ammoniotomy.
And do BV after 2 hours. Sorry, after 2 hours. If you suspect, the next step is to consider ammoniotomy and to do vaginal examination after 2 hours. Agreed? Okay. After
Yes,
that,
doctor.
yes. How to diagnose? The diagnosis of the delay, it depends on the PV after 2 hours. What about the finding after 2 hours? If progress 1 centimeter is good. But if this progress is less than 1 centimeter, this is the confirm there is delay. Because we do BV again in 2 hours and we find less than 1 centimeter. And look for the patient is nullibras or it is a paraslates. Here we consider oxytocin and do BV for hourly. Here, first we do abdominal examination and vaginal examination to assess the patient to exclude the abnormalities, abnormal labor. So if you give oxytocin, you should do BV after 4 hours. Then, if there is progress more than 2 centimeters, this is can go to the routine. We'll do a BV every 4 hours. If progress less than 2 centimeters, we'll consider cesarean section. That is about the how to delay with the first stage of labor. Any question?
Dr. Fatah, I have a question, please.
Yes, welcome.
Thank you so much. Will epidural be a routine for all patients who we will give oxytocin?
Okay. What is the question, please?
Do we have to give epidural for all patients who we will induce by oxytocin?
No, it depends. You should consider. But the analgesia is not routine. And you should consider the oxytocin. Oxytocin itself, it is considered is not routine. You should examine the patient need for oxytocin or not, need for analgesia or not. So it depends on the patient. So it's not routine.
Okay, thank you. Thank you, sir.
Okay. Discuss about the monitoring during labor. I will focus in mainly about the CTG. Before we said this is about the intermittent auscultation in the first stage and second stage, we said that the first stage of labor, the monitor of the fetal heart rate every 15 minutes, and second stage is every 5 minutes. This is the SPA. Now we'll discuss about the CTG. talk about the CTG. My question here, what is the benefit of CTG compared with the intermittent auscultation regarding low risk patient? As you know, the CTG for the high risk. If you use CTG for the low risk, what is the benefit for the patient regarding the intermittent auscultation or the CTG? What is the benefit of the CTG in low risk patient? Is there any benefit?
It avoids
low risk?
unnecessary intervention. It can avoid unnecessary intervention, and sometimes also it can prevent neonatal seizures.
Yes, it is decrease the incidence of neonatal seizure. So the benefit of the intermittent, the benefit of the CTG compared to the intermittent auscultation in low risk. If you use the CTG in low risk, the only benefit is the decrease the incidence of neonatal seizure. So we'll use the CTG for the high risk. This is the SPA question. Also, this is the recall question about the medico-legal issues of the CTG, and the mainly medico-legal issues about the nearly 50% of intrapartum deaths were attributed to failure to recognize the CTG trace abnormalities. This is the most important cause of litigation about most of the cases about this failure to recognize the CTG abnormalities. And this is the recall question. A delay in communication and timely action and a combination of this. The graph shows this is the CTG misinterpretation, and we find this the failure to recognize abnormal CTG, it is the highest. So this is the recall question asked about the misinterpretation of the CTG, and the most common causes is the failure to recognize abnormal CTG. There's others like failure to act, failure to refer, failure to monitor adequately, and inappropriate use of synthesis-non, but this failure to recognize abnormal CTG is the commonest CTG misinterpretation. Okay.
Excuse me, doctor, do you hear me?
Yes, yes, welcome.
Can I ask you a question about the CTG benefit? How do you think it's started? You said that it seems that it reduced the incidence of neonatal seizures. Can you explain that, please?
This is about the Cochrane study. We show this. We do a study about the patient, low-risk patient. These patients have uses CTG, and patient have the intermittent auscultation. And so they found the only difference between both in case of CTG, there is less neonatal seizure. There's less incidence of neonatal seizure. This is the only finding between the two study of the CTG low risk and the intermittent auscultation CTG. Okay.
Okay, thank you, doctor.
Welcome.
Okay.
So what about record keeping? It is also the record question, because there's many question came in exam from this guideline. Anybody ask know about the record keeping?
If normal,
years.
Dr. Fatih will keep 25 years. If abnormal, indefinitely, forever, for life.
Thank you, Dr. Hasnia. Yes, it is keep cardio trace for 25 years if normal. Okay, if there is any abnormalities for the ever for indefinitely, this is for the if there's abnormalities. Yeah. Yes, here record keeping the record CTG trace for 25 years, and if possible, store them electronically. Okay, and in case where there is concern that the baby may have experienced developmental delay, for to copy cardiograph trace and store them indefinitely in case of possible adverse outcome. This is the SPA question, asking about the patient have developmental delay. So we'll keep this forever and indefinitely. Okay. Here we'll discuss about the antenatal and intrapartum CTG. What is the difference between antenatal and intrapartum CTG? Is any difference? Antenatal have other name is non-stress test and intrapartum CTG. So the difference here is that only there is contraction or not. If there's any, if there is recording fetal heart rate without contraction, this is the antenatal CTG or non-stress test. If you record fetal heart rate with contraction, this is called intrapartum electronic fetal monitor. This is the difference between the non-stress test and this electronic fetal monitor. So what about the indication of the CTG? There's many indication for CTG. Here, the mainly indication if there's any meconium instead of LICAR.
Sir, I have a question.
Yes, you are welcome.
Sir, my question is this, that when we do external cephalic version and then after that we do the CTG, would it be, antenatal CTG? Definitely, because there are no contractions. And of course, when a patient comes with decreased fetal movement and of course there are no contraction, then obviously it would be called antenatal CTG. Am I right?
Please, you can repeat the question. What are the antenatal CTG?
Yes. Sir, a patient, she comes with decreased fetal movements, yes, and there are no contractions. Definitely, it's going to be antenatal. Antenatal CTG.
What about the age of the patient? The stational age.
Hello, sir.
The age before 28 or the after 28 weeks?
Sir, after 28 weeks. After 28 weeks.
Yes, we really the finding of the CTG before 28 weeks have problem because we will discuss this later about the development of parasympathetic and parasympathetic. But here the non-stress test different from the intrapartum CTG. So will patient have fetal decreased fetal movement, we'll do non-stress test.
Okay,
so we record the fetal heart rate.
Okay, sir.
If the patient in labor, we'll do intrapartum CTG.
Okay, sir. Okay, sir. Thank you very much, sir.
This is about indication of the CTG. Now we'll discuss about the interpretation of the CTG, which is the most important part in with the intrapartum care guideline. So this is about Dr. C. Bravado, how to interpret CTG, DTR for the determine the risk. So you should determine if the patient have high risk or low risk, and C for contraction. You should read about the rate and frequency and duration of the contraction, and baseline rate is about the assessment of the baseline rate, and variability, bit to bit variability, and this if there's an acceleration or deceleration, and after that you overall assessment. This is important part in nice guideline. Okay, first we'll discuss about the normal CTG. Basically, you know, the normal CTG can be the interpreted. The CTG first will reach the baseline fetal heart rate and variability, acceleration, deceleration. So the baseline fetal heart rate is normally between 110 to 160 beat per minute, and variability beat to beat is about 5 to 25 beat per minute, and acceleration may be or may not. And the normal CTG, there is no deceleration. This is about the normal finding of the CTG. show you this is about the normal CTG. Here, CTG, every big square here is about 1 minute. So here, between these two, this is about 10 minutes. Here is about 10 minutes. And what about the normal speed of the paper speed in the UK? What about the normal? You have two speed, 1 centimeter per minute and 3 centimeter. But in the UK, we'll usually use
1 centimeter.
1 centimeter. Yes, we use 1 centimeter. We use here 1 centimeter. So we have a CTG, we have two electrodes. The one electrode is attached to the fetal scalp to read the fetal heart rate, and the other electrode is placed in the abdomen to record the frequency of and duration of the uterine contraction. This is the TOCO. This is about uterine contraction. Okay, first, you should determine the risk of the patient. Is there any prenatal risk factor, intrapartum risk factor, fetal reserve, and labor pregnancy? So to classify the patient is high risk or the low risk. And determine the risk is the maternal and fetal risk. The maternal is the previous cesarean section. This is the high risk. Preeclampsia, prolonged pregnancy, prolonged PROM, more than 24 hours, diabetes, intrapartum hemorrhage, significant medical condition. This is the maternal risk. And the fetal risk is if there's intrauterine cross restriction and oligohydramnios, preterm labor, multiparous pregnancy, and pre-presentation. This is how to determine the risk. And this graph shows this is about the normal CTG. Okay, what about the baseline fetal heart rate? We just classify the baseline fetal heart rate for reassuring, non-reassuring, abnormal. So if reassuring, if this fetal heart rate is range between 110 to 160 beat per minute, and if classified as non-reassuring, if the fetal heart rate is between 100 to 109 beat per minute or 161 to 180 beat per minute. So this is very important to classify and to pretend CTG. And abnormal, if this fetal heart rate is below 100 beat per minute or above 180 beat per minute. So this is very important to know about the baseline fetal heart rate. Is it reassuring or non-reassuring or the abnormal?
Sir, so I have a question. Can you hear me, sir?
Yes.
So in your previous slide, you have written risk as the breach is one of the risk factors. So does that mean that breach per se is a risk, or breach associated with the other factors gets considered as a high risk? Because like if a mother presents in a breach, does she require a continuous electronic treatment monitoring?
Yes, the most important one in the determine the risk is to know that this is a low risk or the high risk. To classify the patient, this is the high risk or this is the low risk.
Okay, so breach per se is the, you mean to say, is in a high risk?
Yes, if there's any one of this maternal, fetal mentioned before and fetal risk, this is the high risk. So after that, with the assess contraction, we should assess the rate and the duration of the contraction. How to assess the rate? First, to detect this in a tachysystole or not, and to assess the duration of the contraction to know this hypertonus or not, to know the abnormality of the contraction. And after that, to know this is maybe hyperstimulation. So contraction is very important to know about the rate. The normal rate is less than 5 per 10 minutes, and the duration of the contraction is less than 60. The duration. So here the rate and the duration is very important to know about the tachysystole as this hyperstimulation, or this is the hypertonus. We'll discuss later, inshallah. So this is about contraction here. This is 10 minutes. Here is this two contraction per 10 minutes. The normal contraction is less than 5 per 10 minutes. So what is meant by tachysystole? Tachysystole, this is about the rate of the contraction. Normally it's a 5. If there is more than 5 contraction per 10 minutes, period in 2 successive 10 minutes or average over 30 minutes, this is the tachysystole. If you find more than 5 contraction per 10 minutes. If there is a problem in the rate, in the duration, this is the hypertonus. Refer to excessive uterine contraction lasting more than 60 seconds. This is the abnormal duration, lasts more than 60 seconds. So what is the difference between tachysystole, hypertonus, and hyperstimulation? Hyperstimulation is the either there is the problem in the rate or the problem in the duration, but associated with the change in the fetal heart rate. Here, the change only in the contraction rate of the contraction, tachysystole, and the hypertonus is the only in the duration. But if any one of this associated with the fetal change in the fetal heart rate, trace, so this is called hyperstimulation. So this is the difference between tachysystole and hypertonus and hyperstimulation. Is it clear?
Dr. Fat, please, I could not get this thing. In hypotonus, it is lasting for more than 60 seconds, and in hyperstimulation, it is lasting more than 2 minutes, right?
I didn't hear you.
In the previous slide, in tachysystole, in hypertonus, it is.
Yes,
Yes,
hypertonus
in hypotonus,
is related to the duration of the contraction.
yeah, it is 60 seconds, but in hyperstimulation, it is more than 2 minutes.
Yes, in hyperstimulation, there is duration and there is change in the fetal trace. This is the most important.
The contraction lasts for 2 minutes, not 60 seconds, right?
Yes, yes, it can be hypertonus. This is the difference between the hypertonus and hyperstimulation. Here, there is, regarding the duration, here is the change in the fetal heart rate.
It is 2 minutes in
more than 2 minutes. Yes, the contraction lasting for more than 2 minutes. That is the difference between hypertonus and hyperstimulation. Here, more than 60 seconds. But here is the more than 2 minutes. Yes, you are right.
Thank you. Thank you, doctor.
Okay. This is about tachysystole. Here, look for this more than 5. This is 10 more than 5. What about the variability? Variability is the presence of normal fetal heart rate. Variability is one of the best indicator of the intact integration between the central nervous system and the heart of the fetus. So, as you know, basically in the physiology of the heart of the fetus, the fetal heart, the fetal heart rate in the early gestation of the age, about the 10th of the week of gestation, is the control is by sinoatrial nodes. So the fetus have high fetal heart rate. Fetal heart rate is very high, and controlled by sinoatrial node. And after a while of period, there is development of the sympathetic nervous system. So the sympathetic nervous system is responsible about the control of the fetal heart rate. So it is increase the fetal heart rate. And after 28 of gestation of age, the control should be also this between the parasympathetic. So there's competition between the sympathetic and parasympathetic to control the fetal heart rate. So the sympathetic is the increase, fetal heart rate, and the parasympathetic is the decrease the fetal heart rate. Okay, this is the difference. So in fetal heart rate, there is variation, there is variability beat to beat. Here, increase and decrease. So this is the competition between the parasympathetic and sympathetic. So that is why we show there is variability in the fetal heart rate. So this is about how to measure the variability. We select the highest point of the basal heart rate and the lowest point, and to measure the distance between the upper and the lower. This is the variability, beat to beat variability. So this is normally is about 5 or more than 5 to 25 feet minute. This is about the normal variability. So that is why we didn't use the CTG before 28 week. Why? Anybody knows? Why you didn't use the CTG before 28 weeks?
Because the maturation of the parasympathetic system of the baby
Yes,
is not complete.
Maturation of parasympathetic. So if you do CTG in early, before this 28 week, you find there is tachycardia, because the only control is by the sympathetic. So there's high fetal heart rate and there's baseline tachycardia and variability. So that is we use the CTG after 28 weeks. So the variability is simple word. There's competition between the sympathetic and parasympathetic to control the fetal heart rate. Okay. So this is about variability. What about the baseline variability to classify in reassuring, reassuring, abnormal? So we said this is the reassuring baseline variability if the range between 5 to 25 beat per minute. And then reassuring is if there's less than 5 beat per minute for 30 to 50 minutes. This is if there's no reassuring. And we said this is the reassuring of more than 25 beat per minute for 15 to 25 minutes. And we said this is the abnormal if less than 5 beat per minute for more than 50 minutes, or more than 25 beat per minute for more than 25 minutes, or this sinusoidal pattern. This is the classified as the abnormal baseline variability. So this is the reduced variability. This is the reduced variability. And this is the sinusoidal patterns. This is the abnormal baseline. This is the sinusoidal patterns. This is the abnormal baseline variability. So what about the acceleration? Acceleration is increased at least 15 beat per minute above the baseline for at least 15 seconds. So there is at least 15 beat per minute above the baseline, and for the duration is at least 15 seconds. This is the reassuring, and present is the single best indicator of the fetal well-being. And antenatal CTG should always consider it normal.
Excuse me, doctor, can you hear me?
This is about here. This is the acceleration, more than 15 beats per minute, and the duration is more than 10 seconds. What about the deceleration? Deceleration is very important. We have three types of deceleration: early, late, and variable deceleration. What is the causes of early deceleration? What is the causes?
Head compression.
This head compression, yes, head compression. So in mechanism, what is the mechanism of early deceleration? If there's head compression, this is lead to associated activation of parasympathetic nervous system and result in the early deceleration. So will decrease the fetal heart rate. So this is about the minor image for the uterine contraction. So if there's any head compression, can lead to activation of the parasympathetic. So it is not categorized as non-reassuring or abnormal. What about the late deceleration? What is the cause of late deceleration?
Heart compression.
Placental insufficiency.
Fetal hypoxia.
Yes, late is the uretroplacental insufficiency. So this is the cause of the late deceleration. So it's caused by placental insufficiency. And variable deceleration by
Cord compression.
Cord compression.
Cord compression.
So about the cause of the deceleration, the early and late and variable. Maybe this is SPA question. So what about the prolonged deceleration? This is the emergence. What is the definition of prolonged deceleration and prolonged bradycardia? So prolonged deceleration is the reduction in fetal heart rate greater than 15 beats per minute from the baseline and lasting for more than 3 minutes. Look for this is the more than 3 minutes. So in deceleration is normally more than 15 seconds. And here is the more than 3 minutes. So if this deceleration is lasting for more than 3 minutes, this is definitely the prolonged deceleration. What about the causes? Is this reversible causes and non-reversible? The reversible causes is the hypotension, excessive uterine activity, and sustained umbilical cord compression. And non-reversible, the placental abruption, cord prolapse, and uterine rupture. So this is about the prolonged deceleration. Look here, stay more than 3 minutes. Here we said this is for 1 minute. Big square for 1 minute. This is 1, 2, 3, and it's about equally it's about 4 minutes. So this is the duration here. If you estimate here from here and here, this is the duration of the prolonged deceleration is more than 3. So if more than 3, this is the prolonged deceleration. This is about the deceleration and about the causes of deceleration, and this is the recall question. So how to describe the CTG feature regarding the reassuring, non-reassuring. So this is very important table. So before we said the reassuring, the baseline 110 to 160, and baseline variability from 5 to 25, and deceleration if there's non-deceleration or early variable deceleration. This is not categorized as reassuring or not reassuring. In non-reassuring, if there's baseline fetal heart rate is about the fetal heart rate is 110 to 109 or 160 or 1 or 180. And the baseline variability here if this less than 5 for the 30 to 50 minutes or more than 25 beat per minute for 15 to 25 per minute. And this is very important here to look about the deceleration, especially variable deceleration. Variable deceleration have many presentations, so you should classify the variable deceleration either non-reassuring or abnormal. It depends on the duration, about the related to contraction. So if there's variable deceleration with no concern, so this is very important to know about what is the concerning characteristic of the variable deceleration. If the variable deceleration with no concerning characteristic for less than 90 minutes, this is considered reassuring. This is reassuring. You should look for if you find variable deceleration, look for two things. There's concern or not. If there's no concerning characteristic and the duration less than 90 minutes, this is the reassuring. So if there is variable deceleration with no concern characteristic and the duration is about 90 to more than 90, this is the non-reassuring. This is about non-reassuring. Okay? And if the variable deceleration with any concern, so if no concerning, look for the duration. If less than 90 minutes, this is the non-reassuring. This is the reassuring. If variable deceleration with no concerning characteristic equal 90 or more, this is the variable, this is the non-reassuring. If there's concerning characteristic, up to 50% of contraction for 30 or more minutes, this is the non-reassuring. Okay, this is very important. Okay, and if there's variable deceleration with any concerning characteristic over 50 of contraction for less than 30 minutes. Here is up to 50, and here is over 50, and the duration here is about 30 and more, and here is less than 30 minutes. So if you have certain characteristic, look for the related to the contraction and the duration. If up to 50% of the contraction and the duration 30 minutes and more, this is the reassuring, and over 50% of contraction for the duration less than 30 minutes, this is the reassuring. This is regarding the variable deceleration. And late deceleration is over 50% of contraction for less than 30 minutes with no maternal or fetal clinical risk factors such as vaginal bleeding or significant mecolum. This is classified as a non-reassuring. Is it clear reassuring? What about the abnormal? Abnormal, here is the baseline below the 100 and the baseline above 180. And the variability, if less than 5 for more than 50. Here reassuring, less than 5, and the duration is between 30 to 50 minutes. And if you find less than 5 and more than 50 minutes, this is the abnormal. Or there is more than 50 beats per minute and the duration more than 50 minutes, this is the abnormal. Here, if more than 25 beats per minute and the duration between 15 to 25, this is the reassuring. You should look for the duration. This is very important in categorize the CTG. So what about the deceleration? If there's variable deceleration with any concerning characteristic over less than 5 or more 50% of contraction for 30 minutes. For less, if there's any maternal or fetal than 50 minutes. This is the classified as abnormal. Late deceleration for 30 minutes or less if there's maternal or the fetal clinical risk, there's patient high risk, or acute bradycardia, or a single prolonged deceleration lasting 3 minutes or more. So the late will be classified as the abnormal. So this is very important to classify the CTG for normal, suspicious, or the pathological. Is it clear?
Yes, doctor, we are listening and it's very clear.
Okay, thank you. So here we'll discuss if there's variable deceleration. Here, this is summary of the previous variable deceleration, because here, if you remember this, he has many variable deceleration and it's confused really. And we make this diagram to be more simplified, okay? So if there's variable deceleration, look for the concerning or non-concerning characteristic. If there's non-concerning characteristic and the duration is less than 90 per minute, this is reassuring. If no concerning and this is the duration is 90 minutes and above or more, this is not reassuring. This is regarding if there's no concerning characteristic. So if there's concerning characteristic, look for contraction and time. He is confused, okay? Look for contraction. More than 50 or less than 50. And the duration, more than 30 or less than 30. If contraction and time, if more than 50 of contraction and the duration less than 30 minutes, this is not reassuring. And if the contraction is up to 50 or more contraction and the duration equal or more 30 minutes, this is not reassuring. And if more than 50 and more than 30 minutes, this is the abnormal. And
excuse me, doctor, I have a question, please.
Yes, you are welcome.
Back to variability. Why it's considered abnormal if variability more than 25 in less period than if it's decreased?
Yeah.
In the variability. So it's non-reassuring if it's less than
less than 5.
Less than 5 in 30 to 50 minutes, and if it's non-assuring if it's more than 25 in less period.
Yes, if there's less than if less than 5 beat per minute, the duration is 30 to 50. This is the non-assuring.
Yes, I know. But why is the period more in the
duration.
less? Yes, the duration. It's in the variability in more than 5. It's 30 to 50.
It depends on it depends on the variability less than 5 or more than 25. Is the less than 5, we need long time. We look for the 30 to 50 minutes. If the variability 25 beats per minute, just we need short time, 15 to 25 minutes only.
Why the time is shorter? Why the time is shorter?
You need the why we said this is a reassuring.
Yes. Why it's a shorter time than the decreased? Is it? You understand what I'm saying?
Yes, I understand. You talk about the time.
Yes.
Sorry, can I answer this? Our colleague
different. This is the reduced variability, and this is more than 25 beats per minute. There is big difference between both.
I mean, does it reflect that the baby? I mean, does it reflect that the baby is in more stress if the variability is increased?
No. Here is different. Here, the effect of the variability less than 5 is different as more than 25. It's not equal. It's the same. There is difference. Okay.
Okay. Thank you.
Okay. Welcome. Is it clear here is variable deceleration? So what about the late Deceleration
Dr. Fahd,
also.
sorry, I think I understand the question. Our colleague, she was asking you about why the duration is different in terms of decrease the beat to beat or increase the beat to beat.
Yes.
It was the same question for me, but it sounds that the reality. It's that when is that the beat to beat is decreased is less than 5. If the duration it will be more than 50 minutes, it will be non-reassuring, right, doctor? Throughout the pathology,
30 to 50
it
minutes.
will be
Yes,
30 to 50 minutes.
how many minutes, doctor? 25 or 50 minutes? If it's less than 5.
Look for the variability. Is the less than 5 or more than 25? It is very important to look about the type of variability. The duration is the less than 5 and more than 25. If the variability is less than 5, the duration is from the 30 to 50 minutes. This is very assuring. If the beat 25 beat per minute,
yes.
The 25 beat per minute, look for the duration. If between 15 to 25 minutes, this is the reassuring. So the time here is different.
That's right. Yes.
The beat to beat.
That's right. The time is different. Yes.
Yes, it's the time different. Yes, actually, because there's 5 beat, less than 5 beat, or the more than 25 beat per minute. So the effect on the fetus is different.
It sounds that to be, yeah, doctor, I think that's a similar question that our colleague, she was asking. It sounds when it's to be very rapid, increased beat to beat variation, which is to be above 25 beat to beat variation in it's 25 minutes about it's non-suspicious, suspected. It means to be very rapid. It is very important. Even the shorter duration, it is more concerning, right, doctor? If it's above 25 beat per minute. Yes.
Here we need less time.
That is
more than 25 per minute.
That's right. Yes,
to classify it as the non-reassuring, not like less than 5 beat per minute.
That's right.
The time here is different.
That's right. Yes. That's right. Yes, yes, doctor. Thank you.
So this is about, this about the deceleration also. If look for the time and the duration less than 30 minutes, if no maternal risk, this is not reassuring, or if less than 30 minutes. And if there is maternal fetal risk, this is abnormal. And more than 30 minutes, this is abnormal. So this is simply classified of the late deceleration. So what about the concerning characteristic? So we'll discuss this variable deceleration with non-concerning and with the concerning. So what is the concerning characteristic of the variable deceleration? We have 5 concerning characteristic. So what is the concerning here? Long lasting more than 60 seconds. As you know, the variable deceleration, the duration is about 15, lasting more than 15 seconds. So if this is the variable deceleration is lasting more than, here the duration here is more than 60 seconds. We said that the definition of deceleration is lasting more than 50 seconds. So the concerning feature here is about 60 seconds. So this is the duration in more than 60 seconds. This is one of the concerning variable deceleration. The second is reduced baseline variability within the deceleration. Here, normally there is variability in deceleration, but if there is reduced variability, like flat, like just flat. So this is here is reduced. There is no variability or reduced variability. So this is the concerning feature. Normally should be like that. Okay, this is the normal variability. So if there is reduced baseline variability, this is one of the concerning characteristics. And the third one is the failure to return to the baseline. So if you this is the baseline, this is a deceleration and failure to retain. So difficult to retain to baseline. Okay, this is one of the concerning feature of the variable deceleration. By physics shape here like that. This is the by physics shape and no shouldering. Normally there is shouldering. This is the baseline and normally should be shouldering, but here there is no shouldering. Should be here shouldering. This is the shouldering and should be the non-concerning feature, the presence of the shouldering. If there is no shouldering, this is the non-concerning characteristic. So this is about the non-concerning feature. You should look for the variable deceleration. If you find lasting more than 60 seconds, this is the one concerning reduced baseline variability, failure to return to baseline by physics wave and no shouldering. This is about concerning feature.
Dr. Ifat, please can you explain shouldering again?
Yes. In normal deceleration, there's shouldering like that. Okay. Here, if this baseline, normal shouldering here. Okay. This is the normal shouldering, like shouldering. Okay. This is the normal shouldering in the variable deceleration. If you find like that, here there is no shouldering. So here is not going up and down. So if there is no shouldering, this is the one of the characteristic feature. Is it clear?
Yes. Yes, thank you.
Okay. Okay, welcome.
Excuse me, sir.
Welcome.
Assalamu alaikum. Is there any difference between failure to return to baseline and the W shape by physics?
What is the difference between failure to return baseline and by physics?
By physics.
Okay. By physics here is like that. Here, the normally, if this is baseline, the normal here, the shouldering and the only shape here. This is the here. This is the normal. Okay. If you have by physics, this is the abnormal. Or the end of the deceleration like that. This is the normal. If there is two by physics, this is the abnormal. Okay?
Excuse me, sir.
Abnormal in
Excuse me, sir. I have a different question. Let's say that the fetus heart rate was about 150. Then after deceleration, it comes back around 120. Does it considered normal? For an example, it will not return to the same baseline. Different baseline, but less than the first one. Does it consider normal?
If it failed to return to baseline, this is one of the concerning characteristic. We should look if said in that scenario.
Before let's say for an example, before the deceleration, the baseline was around 150. After the deceleration, it comes back, but not to 150, to 120. Both baselines considered normal, but after deceleration, it's less than the first one. Does it consider normal?
Okay, I got the point. Inshallah, we'll discuss it later because we have a lot of question, question, AMQ and SP. And inshallah, we'll discuss everything. Okay, don't worry.
Inshallah.
Okay,
Thank you.
We'll discuss that. Inshallah, we'll open discussion for after the end of the lecture.
Thank you, doctor.
How to manage the CTG? Okay, this how to categorize the CTG. After we classify this reassuring, non-reassuring, and abnormal, we need to categorize the CTG for the normal, unsuspicious, and pathological. So we said this is normal if all the features are reassuring. All the features is reassuring. So what was the management? It's just to continue CTG. Okay, no need for intervention. So if there's, you find one reassuring feature. What reassuring? You remember what reassuring feature? Like what? Like the baseline 100 to 190, or 160 to 180, or variability less than 5 beat per minute for 30 to 50 minutes, or more than 25 for 15 to 50 minutes. Or this variable deceleration and late deceleration. We talk about the non-concerning feature more than 90, or non-concerning feature up to 50% of contraction, and the duration for 30 or more. So if you find one of this is non-reassuring, this is classified as suspicious CTG. We need to do conservative measure. Okay, we'll discuss how to do conservative management. If pathological, we said pathological, we found if when abnormal. What is the abnormal feature? If there's tachycardia, or there's pulse baseline, more than 180, or baseline more than 100, or sinusoidal in the baseline variability, or there is variable deceleration or late deceleration. Oh, this is about the abnormal feature or two non-reassuring feature. So if this is the case, the CTG is diagnosed as a pathological, you should exclude the risk factor like co-prolapse, there's any suspicion of the placental abruption or uterine rupture. So you should correct the causes of the hypotension or uterine hyperstimulation, and after that you should do conservative measurement, and after that you counsel the patient to do digital fetal scalp stimulation, and then fetal blood sampling, and then expecting the pairs. So we have to start show how to management of pathological, because a lot of question AMQ exam came in exam asking about how to manage and how to deal with the pathological CTG. So what is the conservative measurement? So encourage the woman to mobilize or to adopt alternative position, to change the position to avoid being supine, and also over intravenous fluid if the patient hypotensive, and reduce contraction frequency if the patient have hypertonus or they have tachysystoles, reducing or stopping oxytocin, and overing autocolytic drugs. This is about conservative measure. What about the fetal scalp stimulation? The first step to manage the pathological CTG will do conservative measurement. If there is still pathological CTG, we'll do fetal scalp stimulation. If there is still fetal scalp stimulation and still pathological CTG, we'll do fetal blood sample. If there is still pathological after doing fetal blood sampling, we'll expected delivery. This is the right way to deal with the patient with the pathological CTG. We'll discuss later, inshallah. The fetal scalp stimulation, if the cardiograph trace is pathological over the digital fetal scalp stimulation. This is lead to acceleration in the fetal heart rate. Only continue with the fetal blood sample if the CTG is still pathological. If the digital fetal scalp stimulation during BV lead to acceleration in the fetal heart rate, regard this sign the baby is healthy. No need to do fetal blood sampling. So here it's very important the CTG after fetal scalp. If you find it's still pathological, we'll go to the fetal blood sampling. If there is acceleration, this is the baby is healthy. So you should review the patient and decide what you want to do. So what about the fetal blood sampling? So fetal blood sampling is very important in pathological CTG. This is the equipment of the fetal blood sampling. So what about the classification for fetal blood sampling result? We classify the fetal blood sampling for the normal, borderline, and abnormal. So we look for the pH and lactate. If the pH is 7.25 or more, this is the normal. The fetal blood sample is normal. Or the lactate is 4.1 millimole per liter or below, this is the normal. And most in exam will give you the pH. Borderline, if the pH between 7.21 to the 7.24, this is the borderline, and the lactate 4.2 to 4.8 millimole per liters. This is the borderline. Abnormal, it is if the pH is 7.22 or below, or the lactate 4.9. So this is very important because you should know this is the normal fetal blood sampling and border or the abnormal, because the intervention is depend on the finding of the fetal blood sampling. Okay, we'll discuss it because a lot of question in exam and recall asking about, you give the figure here and asking about the next steps. So how to interpret fetal blood sampling? So if normal, or this is the borderline, or this is the abnormal. So if the result was normal and no acceleration with fetal scalp stimulation, repeat more than 1 hour. So if you do FPS, fetal blood sampling, you find this normal, but there is no acceleration. So if there is no acceleration, you should repeat fetal blood sampling after 1 hour. If the result was borderline and there is no acceleration with the fetal scalp stimulation, repeat more than 30 minutes. If abnormal is borderline, we repeat after 30 minutes. If the result is normal, after 1 hour. So this is the difference between the normal pH with no acceleration and the borderline fetal blood sampling with the acceleration. Here we'll do after 30 minutes. If the fetal blood sampling result is abnormal, you should do inform the Syrian obstetrician and the neonatal team and talk to the woman and her peers about what is happening and take her preference to account and expected support. This is the role for said fetal blood sample or not. So this is the questionable because you discuss this with the consultant. So if this is abnormal, you should call the consultant or the Syrian obstetrician and discuss with the neonatal team and counsel the patient about the condition and expected the best. So this is the abnormal. And discuss the consultant if you need the third fetal blood sample. This is the recall question. If you do 2 fetal blood sampling, you should first discuss with the consultant before to do the third fetal blood sample. This is about the intermittent fetal blood sampling. Here, look for this. We'll summarize that about fetal blood sample. If the patient normal, repeat 1 hour. If the patient this borderline, we repeat within 30 minutes. And then we do fetal blood sample. If this fetal blood sample becomes normal, so we'll continue as normal. And if this is still borderline, this is the second fetal blood sample. So for the third, you should seek obstetrician advice and discuss about the third fetal blood sample. And if this fetal pH is abnormal, you go direct for the urgent pairs. So this is, if it's abnormal, the only way for the management of patient, you should do urgent pairs. So this is the difference if there's fetal blood sample is normal or borderline is abnormal. Is it clear?
Yes, it's clear.
Okay, this is very important slide. How to manage the pathological CTG. Okay, so first, if you find this pathological CTG, if one abnormal or too reassuring, this is classified as CTG, a pathological CTG. So how to manage this? So first, we look for the any risk factor like abruption placenta, cord prolapse, and how to manage it. Okay, then after this is still pathological, we'll do conservative management. So the first line here to do conservative management. Okay, if there is still pathological after implementing conservative measure, we'll do fetal scalp stimulation. So if there is still pathological after fetal scalp, there is no acceleration, so we'll do fetal plus sample. Fetal plus sample, it depends on the it is normal or borderline or this is the abnormal. So if there is fetal scalp stimulation, is you find in CTG there is acceleration, it's reassuring. So you should review the whole clinical picture. This is the right way to deal with the patient with the pathological CTG. Is it clear?
Yes, thank you, sir.
Yes, sir.
This is about
Assalamu alaikum,
how to
Dr.
deal with the
Fateh.
patient.
Assalamu alaikum. Assalamu alaikum, Dr. Fateh. Dr. Fateh, can we get the maybe be able to get the record of this session because we are having duty and we have to stop over here, please. Excuse me, sir. Assalamu alaikum.
Wa alaikum assalam. You are welcome.
Sir, we have our duties, so we won't be able to continue with the discussion. We are not able to continue with the discussion because we are having duty. So maybe be able to get the record of this session.
Yes, inshallah, our recorder will be available in website, inshallah. Don't worry, inshallah.
Please, thank you so much. Jazakumullah khair.
Today, inshallah, today will be available, inshallah. Okay. This is about management of hyperstimulation. So, term removal of any remaining stone, tell, and remove stone pessary if they still inside, and stop oxytocin and change the position and assess blood pressure and fetal heart rate, IV fluids. This is, and then after that we do pelvic examination, and this is about how to deal with the patient of hyperstimulation. So what about the second stage of labor? And the duration and definition of the delay in the first, the second stage. We discussed before and about the definition of the delay in the first stage. So what about the second stage? So in the leprous woman, 1 hour passive and 2 hours active. So this is a suspected delay after 1 hour of active push. Basically, you know this about 1 hour passive and the 2 hour active. So if you please mute your mic. Okay. And this is about the duration and the definition of the delay in the second stage. So please mute your mic. Okay. And this is about the second stage. So we said this is the suspected delay in second stage of labor in leprous woman if you suspect delay after 1 hour of active push. So the birth is expected to take place within 3 hours, 1 passive and 2 hour active of the start of the active second stage in most women. So delay in the active second stage when it is had last 2 hours. Undertake an operative vaginal pierce if birth is not imminent. So what about the Paras woman? Suspect delay after 30 minutes of active pushing, and in the nulliparous after 1 hour of active pushing. So this is the difference between the Paras lady and the nulliparous woman. So in nulliparous woman, suspect delay after 1 hour of active pushing, and Paras woman suspect delay after 30 minutes of active pushing. So, and suspect when? If nulliparous after 1 hour of active pushing over support, rupture of membrane, and with or without oxytocin. So in case of nulliparous woman, suspect delay after 1 hour with support patient over support and ammoniotomy and minus or plus with the oxytocin. In multiparous woman, after 30 minutes of active pushing over support ammoniotomy. So this is in case of suspected. If confirmed delay, if there's prolonged second stage, when nulliparous after 2 hours of active pushing, and multiparous after 1 hour of active pushing. So here we'll discuss how to deal with the patient with the suspected and delay in the second stage. So we said if suspect delay in nulliparous after 1 hour of active pushing, and suspected delay in multiparous woman after 30 minutes. So if there's multiparous, delay suspected if inadequate after 1 hour of active pushing, and the parous here if there is active second stage after 1 hour, 30 minutes. Okay, here is about 1 hour. Sorry, here is about 30 minutes. 30 minutes. Okay, yeah, suspected delay after 30 minutes. Okay, so you should over vaginal examination and advice for ammoniotomy, same like first stage of labor, and if the membrane intact, and over support and encouragement, and consider analgesia and anesthesia. So if the birth is occur after 1 hour, so you patient management at the third stage. This is the normal pathway. Here, suspect delay, and after that, ammoniotomy. The birth occur within 1 hour, and so you manage as the third stage. If there's no birth within the birth within next hours, so the total active is 2 hours. So we said the normal duration is 1 hour for passive and 2 active. So suspect after 1 hour of active, then after waiting 1 hour and doing ammoniotomy and support, and still there is no pairs. So this is the diagnosis of delay in second stage. So this is confirmed. This is a delay. If complete 2 hours of active pushing without pairs and no pairs, this is the confirmed delay in the second stage. What is the next step? You should assess every 15 to 30 minutes. Every 15 to 30 minutes, you should assess this patient and don't start oxytocin. If there's good progress and there's pairs care, so we'll meant as said. If after 50 to 30 minutes and there's still no pairs, you should consider instrumental pairs, instrumental vaginal delivery. Advise cesarean section if the vaginal pairs not possible. So this is about how to manage the patient is confirmed delay. The choice of an instrument depends on the balance of clinical circumstance and the practitioner experience. Use tested effective analgesia, and if decline or if concerned about the fetal compromise, use potential plug with local anesthetic or to perineum. This is if there is confirmed delay, you should assess every 15 minutes. If no pairs, consider instrumental or advice for cesarean section. This is about how to manage the patient with suspect delay in second stage of labor. Is it clear? Okay. What about the third stage of labor? We have two options of management, either active management or the physiological management. The duration of the active management is the 30 minutes. If more than 30 minutes, the third stage of labor take more than 30 minutes, this is the delay in the second, suspected delay in the third stage. So the active is about 30 minutes, the duration will give her 10 international units centesnon IM. The physiological management will last for 30, 60 minutes, and there is no ureterotonic tracts and no cord clamping and delivery by the placenta by maternal effort. This is about the physiological management. So this is comparison between the active and physiological management of the third stage regarding the complication like nausea and vomiting, the hemorrhage and blood transfusion. This is also this is the called question. Here in the active management, the nausea and vomiting, the nausea and vomiting is 100 to 1,000 women. It's about 10%, and the duration here is the shorter if there's active management, and physiological management is the longer. And the nausea and vomiting here incidence is 100 to in 1,000 women, okay? And 50 in 1,000 women is a 5% in physiological management. So the nausea and vomiting more incidence in the active because this is maybe side effect of the oxytocin. And hemorrhage of more than 1 liters, the incidence is 13 in 1,000 per 1,000. It is about 1.3% in active, and here is more in physiological management, 29 in 1,000. It is about 3% is more than active because here we use oxytocin ureterotonic drugs to reduce the incidence of hemorrhage. And blood transfusion is definitely is more in physiological, is about 40 in 1,000. It is about 4%, and here is less, 1.4% in 14 in 1,000 is active because we use here ureterotonic drugs to decrease the incidence of the hemorrhage and definitely with the decreased need for blood transfusion. This is about the comparison between active and physiological management of the third stage. How to diagnose the delay in the third stage and how to manage it. So it depends on it is physiological or this is active. If more than 30 minutes after birth with active management, this is the delay. And more than 1 hour after birth with physiological management, this is the delay in physiological management. So if this active management of third stage and there is still the placenta is not delivered more than 30 minutes, you should secure IV access and give her oxytocin. If this oxytocin is effective and placenta is delivered, this is go for the normal management. If this oxytocin not effective within 30 minutes and the placenta is still not delivered, use analgesia or anesthesia for assessment. If women report inadequate pain relief, stop assessment and address this need. Use effective regional analgesia. And if this placenta deliver is okay, this is you can manage her as the third stage. This is about how to diagnose the delay of the third stage. This is all about the intrapartum care. So we have a lot of question here. We'll discuss the question. This is about the question 29. Who will share?
Dr. Fad, you want we read the question and answer?
Yes, please. Yes, please.
So shall I, for example, I start to read?
Yes,
or you will read? I don't know.
Read and answer
Okay.
the question if possible.
Okay, you might help us for the answering as well. Okay. Yeah. Thank you. That bless you, doctor. Okay, question 29. A 30-year-old woman presents in spontaneous labor at 38 weeks gestational weeks. Following a spontaneous rupture of the membranes, she makes excellent progress to 6 cm. And CTG comments following maternal request for epidural analgesia. All maternal observations are within normal, and the CTG shown next slide is representative of the last 1 hour, which it will show. Okay, vaginal examination and fetal scalp stimulation was performed at 4:14, and clear liquid was noted. You have been asked to review at 4:35, which is about in a short time when the clear liquid came. And then, so what is that? So we didn't see the pattern of CTG, doctor.
Yes,
change the no. Yeah. So, and then the option is change the maternal position plus IV liquid, fetal option B, fetal blood sample, then repeat fetal scalp stimulation, review CTG in half an hour, and the last option subcutaneous terbutaline. Okay. So this is showing some very deep drop of the fetal heart base. The decelerations are there, and the contractions also are very regular. I mean, it's more than normal range. It looks like that the patient is hypertonic. It's better we stop if she's taking oxytocin. The options, if I need to see the options, she looks like hypertonic, and at the peak of the yes, doctor, because at the peak of the contractions there is a So in that case, so is it said what is the next step, or what's the question you have, Venice, or what is the most appropriate? I would say in this case, repeat fetal. So I would say the first one, we always do change maternal position and IV fluid. I don't know if I'm right or not.
We also change
because there is no
position and IP.
Yes, I would say option A. But if there was oxytocin, I would say firstly DC discontinue the oxytocin if she was on the undertaking of
scenario.
We can do fetal blood sample.
Vaginal examination and the fetal stimulation. This is the pathological CTG, okay?
We can do fetal
so
blood
which
sample.
option is better, doctor? B?
Already fetal scalp stimulation was done. And
next step is fetal blood sampling.
And
E
still
yes,
CTG.
What about E option?
And
B.
So in that case, we should do, if the fetal blood, we should do, doctor, fetal blood sample.
Right. Because this is the still pathological CTG, and do conservative measurement, and after vaginal examination, fetal scalp stimulation, report still there is no deceleration, no acceleration. So we need to do
fetal blood sample.
Yes. This.
Yes, doctor. Yes. So it's suppose. Now I got the key point of the question. It's supposed that it's mentioned that the fetal scalp stimulation is done.
No
We consider
here.
that even the yes. So option
No,
B, yes, doctor. Option B, yeah.
Yes, this you should do fetal blood sample. Thank you so much, Dr.
Okay.
Dr. Fat, just one query. In this CTG, is it showing this tachysystole or hypertension? Because it is just 4 contractions in the 10 minutes. Is it showing any tachysystole or hypertonus? I don't think so.
The previous CTG?
Yes, Dr. Fat, in the previous CTG.
Yes. Yeah, look for this is the 10 minutes. 1, 2, 3. It's about 3. So
yeah, so it is
normal.
the contraction.
3 to 4.
It's normal.
No tachysystole.
Excuse me, sir.
Look for
I can't see the CTG.
There's
Hello?
concerning feature by physics.
Hello, sir.
Yes, this is biphasic. Only there is nothing wrong with the contractions.
Yes. So still pathological CT. The next question. Who will share?
Can I take this
Do you
question,
want
Dr.
I
Fat?
read or?
You can read it, okay.
I carry on? Shall I carry on?
Yes, you can read.
Okay. Question 30. A healthy 25-year-old woman presents in spontaneous labor at gestational age of 39. All maternal observations are within normal and the cervix is 8 cm. A deceleration is detected on intermittent auscultation and CTG is commenced. The entire CTG is showing in the image next slide. Then we should find the option that continues CTG for the rest of the labor, return to intermittent auscultation, then fetal blood sampling, then continuous CTG for another half an hour, and the last option, expedite delivery. 8 cm.
We'll see the.
She's 8 centimeter. Okay.
The CTG.
Okay, she's intermittent. Okay.
Can go back to
she lives okay. She can back to the intermittent auscultation.
The
Doctor, this is normal. This is normal.
I can't see the CTG. The CTG is not visible.
She can go back to her normal intermittent auscultation.
Doctor, I would say option B. Option B. Return to intermittent. Option B, doctor.
Yes, agree with B. Option B.
We say B.
D or P, Dr. Seva? P, yes. Because
B
this
or?
is normal CTG.
It will be V, return to intermittent. Normal CTG is 20 minutes normal.
Intermittent, doctor. Yeah, intermittent. Option B. B.
Yes, option B, you are right. Option B, yes. So you can return to the intermittent auscultation.
Intermittent. Yes.
About. Okay, question second. MQ. Sina?
Okay, question 31. For each of the case history described below, choose the single most appropriate initial management from the above list. Each option may be used once, more than once, or not at all. So yes. Lots of options.
First, you should read the scenario first, okay?
So yeah, we need to read the scenario. Where is the scenario, doctor? The question, I mean.
Don't go immediately for the question. Just go to the question first.
So the question, Yes, doctor, I found the question. She is 35-year-old of 2 children. She presents in spontaneous labor, gestational age 39, and she has previous C-section for breech presentation, followed by a spontaneous vaginal delivery at 12 o'clock. The cervix is 7 cm with a direct OA position, which is good. And then at 3:10, strong contractions detected. At 4 p.m., at 4 o'clock, the cervix is 7 centimeter, and the contractions are inappropriate. Yes, doctor?
Coordinates.
What is that? Incoordinate is irregular. Yes, irregular, occurring 2 to 3 per 10 minutes. The CTG is normal. So it seems that at 12 o'clock she was 7 centimeter.
Yes.
And after
4 hours,
3 hours,
in spite
yes,
of strong contraction, there is
exactly. So
yes, 7
so it seems,
centimeters.
The
doctor,
delayed
the
second stage.
yes,
Yes,
so
No.
she is not
Not second stage.
the CTG
It's not
is
second stage,
good.
Ruth.
She is in the
It's still in
first stage
first
of
stage.
labor. She is in the first
Yeah,
stage.
established first stage. You
The
do have
contractions
Newton.
are not good.
This is
So
look
let
for
us,
the option.
doctor, I need to see the options, please. Can I see the options, please? Yeah. So in this case, that we are
Do have
suspected to
Newton.
the
Yes, not done.
delay of labor, and the
Patient have
contractions are
previous
not very
cesarean
well.
section, and this
Yes,
exactly.
So
It's confirmed
so I think in
delay
that
in second
case,
stage and cesarean section.
Sure, yes, you should go
so
with
I
the
think the
cesarean
best
section,
thing,
because this is patient have high risk patient, and they suspect delay, and this is the secondary arrest, because after 4 hours we do the PV and the same finding. There is still 7 centimeter in spite of a strong contraction. So the right
so you
decision
mean we do cesarean, doctor? We do
cesarean
cesarean?
section. Yes, this is the best for
This is
Okay.
labor dystocia by cesarean, I think.
agree with cesarean section.
Now, please, is there no
Also,
room
the
here
patient
for
is
Yes, agree.
multiparous. So the patient is multiparous,
It's high
and
risk
she
patient.
had a cesarean previously, then followed by a VBAC, and now there is a confirmed delay in second stage of labor. Although the CTG is normal,
It's not
but
second
she
stage,
shouldn't be
dear.
given more
The
time,
patient,
and we should go for cesarean section.
Yes, the CTG is normal, but you find in here the
yeah,
cervix
CTG is okay.
at least 7
But she
centimeter.
shouldn't be given more time because they're
See,
incoordinate
difficult to give her time, because we have give her more than 4 hours,
contractions.
and there is still the same finding, and in spite of the strong contraction. This is the secondary arrest, and secondary arrest is there may be abnormal position.
Yeah.
This is occipital anterior position. So there may be abnormal position. You need to do cesarean section. Okay?
So the best option would be C-section, right? Option B.
Cesarean section. Yes.
Cesarean.
Excuse me, sir. You say incoordinate contractions occurring 2 to 10,
Yes.
2 to 3 in 10 minutes, which is not adequate. I think the adequate contraction is about 5, in as much as about 2 to 3. I don't think it's still inadequate. This woman should need augmentation of labor.
Dr. Fat, will if amniotomy,
This patient have a strong contraction. No need to give her oxytocin.
Dr. Fatih, excuse me, this patient is, you told that incoordinate.
Incoordinate.
Yes, Dr. Fat,
Contraction.
this is my question. Yeah.
This
Can
patient
use
have one
augmentation to
VBAC.
coordinate it
You
to
have
make it.
one
Yeah.
VBAC. I think
Yes.
her success rate, it will be more than. I think we will not should go for cesarean section immediately. I think so.
Yes, Dr. Fat, actually, this is my concern also, because it mentioned the patient having incoordinate. It means they are not very effective contractions. It sounds it's not very effective contractions.
is
Yes.
ARM amniotomy?
Yes. This is patient is stuck in 7 centimeter. This is
Yeah, but
the definition of
amniotomy.
secondary arrest. If you have a patient diagnosed as secondary arrest, you should manage by cesarean section, because the patient has taken the 7 centimeter. If you show the partogram, it is cross the alert line and the actual line. So in 7 centimeter, after 4 hours, there is still 7 centimeter. You should manage by cesarean section. This is the management of the secondary arrest.
But what about the amniotomy, Dr. Fat? Like, we cannot do amniotomy.
Sorry, are we just going to proceed to cesarean section without any intervention?
Okay, Dr. Zanoba, you can continue.
So,
Dr. Fat.
Yeah. Who will answer?
No, I think at least there should be some change in the reassessment of the PV because it is stuck at 7 centimeters. So there is no point in thinking of normally delivering her because there is no change at all. Only if it is less than 2 centimeter or at least 1 centimeter change, we can try and do some amniotomy or oxytocin drip, something like that.
Yes.
Okay. Yeah. Okay. So we choose finally C-section, cesarean.
Yeah,
Okay.
because we give the patient more than 4 hours, and
Yeah. Okay. So it sounds like that she arrested at 7 centimeter dilatation. No any change.
You give you a scenario, and the patient arrested at 7 centimeter. This is secondary arrest. You should choose immediate cesarean section. No intervention. Just cesarean section for secondary arrest. This is the abnormal level.
Especially she is a case of previous cesarean as well. She's been, yeah.
And this is the abnormal pattern of the labor. So you choose the cesarean section.
Okay.
If Dr. Fatha, if the patient was with low risk and also with secondary arrest, how we are going to manage?
If the patient is stuck in 7 centimeter, this is the diagnosed as secondary arrest. If the secondary arrest, if you diagnose as secondary arrest, you should manage mainly by cesarean section. No
Even if with low risk? Even if with low risk, Dr. Fat?
For this arrest, doctor, the patient had this.
Arrest, this is managed by cesarean section. You should manage by cesarean section, especially in multiple.
If this 4 hours,
is different. Maybe it depends.
Yeah, you will
on
review the
other
whole
factors.
picture. You will examine the patient also.
And in the yes, it depends, because this is in this scenario you give this patient have previous cesarean section.
Yes, I think if this is very particular case because the patient also is a high risk because of the previous C-section. If the patient was not have the background of previous cesarean, and as the similar question that our colleagues are asking, that we found that she was arrested like at 7 cm during 4 hours, we could think that reevaluate to check the irregulation of the contractions.
If multiparous and stuck in 7 centimeter, you should go for cesarean section. If there's nullable, you should look for the this. Yes.
Can I ask one question? If the patient delay for 4 hours, at least for 4 hours, for as you told, at least we must give the patient chance if she's low risk with the augmentation or whatever ARM or whatever oxytocin. I think is 4 hours, then we can tell after that she had delay. Am I right? Without contraction, you cannot, good contraction, you cannot tell that she is delaying.
Okay,
I think so.
You, okay. Okay, the question 32.
Question 32. Okay, there are loads of options for each of the scenario case described below. Choose the single most appropriate management from the above list. For each case, you might choose once or more than once or not at all. So the question is next page.
Okay.
Okay, the case is the patient is 40-year-old. She got 3 previous NVD, vaginal delivery, for induction of labor at 42 weeks. She has artificial rupture of membrane at 9 a.m., multiple cervix, and oxytocin then commence after 2 hours at 11 o'clock. Epidural analgesia is inserted at 1 p.m., which is ineffective. As a consequence, the maximum dose of the oxytocin administered, which is 4 milliunit per minute. Epidural is recited at 7 p.m. and at 11 o'clock, 11 p.m., she has adequate analgesia. The oxytocin dose is 16 milliunit per minute, and she has 3 to 4 contractions in 10 minutes. Then the cervix now is fully effaced, but 2 centimeter dilatation, and the CTG is reactive. So it seems she has very slow progression in dilatation, only 2 cm. And she has 3 to 4 contractions per 10 minutes and fully effacement. So what's the best next step? I would say I think increase dosage of oxytocin. This is my option. I don't know. Let's see.
No additional intervention at this
Continuous
stage.
dosing as current
Yeah,
dose.
but otherwise,
At this stage.
Continuous current dose.
because she is still in the latent phase of stage 1, she's in latent phase. Contractions are optimum.
But you gave 16 units already.
She's 16
No
units,
additional
yeah.
intervention at this
Yeah, and the CTG also is good.
Continuous dosing as current dose.
Sir, I think it's
Because at
option
the
A,
last examination,
and since everything is going on fine, and the CTG is fine, and she's relaxed with the pains she's experiencing, and she's okay with the epidural analgesia she's giving. So I think, no additional intervention should be required, and she should be given some time, and she should be reassessed after an hour or so.
I think continuous
Yes, maybe
oxytocin.
option A is
I think it's continuous dosing at current dose. Since the last examination, she was having adequate contraction and she's 2 cm dilated. It was during the last examination she was having 4 contractions or what.
Already
So
she
I
had
think you should continue dosing at current dose and re-examine maybe in the next 2 hours or what.
Yes, she should be, given time, and she should be reassessed after an hour or so time.
Yes.
And
so it seems option A is better.
Yes. Option A is better.
So I think I.
Yes, it seems better. Yeah, no additional intervention. So is it the correct answer, doctor? Doctor, we conclude.
Yes. Nice.
Okay, was it A?
Oh, continuous dosing at current dose. I made it.
Oh God! So continue.
Yes.
Continue at current. You said I. Yeah, I think you said I. Yeah, you chose I. But was a bit tricky because even option A, it sounds similar. Yeah.
If you check the last from the whole story, the last examination, she was having contraction, and that was when you have 2 centimeters. So you have to give the patient more time. You understand why continue at that rate? She was having that good contraction.
Sir, could you please kindly explain that what is the difference between the option A and option I then,
Option A say no additional intervention. No additional intervention means maybe either you stop the oxytocin and leave the patient at that stage. But that time you cannot just stop the oxytocin.
So like in
Continue
option
at
A,
that
we have
stage.
to stop the oxytocin, and in I, we
I think so. No additional, yeah.
I think the oxytocin is started for induction. So she just entered in getting the regular contraction. So we will continue the same dose of oxytocin, because the oxytocin not started for
Yes.
augmentation, it is for induction. And she's still in 2 cm latent phase and reached to maximum dose, and she got the contraction. So we will continue the oxytocin, and we will give her time to go in active labor. That's why I wrote I also.
Don't forget this patient on epidural also.
What? Epidural what you said?
Don't forget also this patient on epidurals. That's mean her progress even it will be also slowly.
It will be a slower.
No, we are not looking for the progress as such in this scenario, because we induced her by oxytocin, and we just gave her epidural to release the pain. So it's not a matter of progress. She's just started to have a contraction to go in active labor. Still, she's in
You
latent
gave
phase.
her because already she had spontaneous rupture of my brain.
Yeah. So we started with 0 level to her, and we reached to the getting good contraction. So we will continue the syntocinon on the same dose, because our aim to get the contraction, and then after that we will look for the progress of labor.
Yeah, I better, because usually I think the type of answers that like we picked option A, we said that no additional intervention is. I think this type of answer usually are not the correct. When it's a no, nothing to be done, usually they sound something is wrong. Better we don't take this type of answers in the exam. This
No,
is my experience.
no, we cannot take it as a hard and fast rule. Be careful for this, because really sometimes we don't need any intervention at that moment, so we can't take it as hard and fast. But in this scenario, as I mentioned you, this seems to be they started oxytocin for induction. Now she start 2 cm and start contraction. So our aim achieved. Now we will continue same dose of oxytocin, and we will look for the progress. You got my point. That's why the I is the proper answer.
Yes. However, I sounds more detailed and correct to the patient's situation compatible. Yeah.
Yes, that's fine. Thank you.
Okay, then I'll start the next question. I'll read the next question. Question number 33.
Okay.
A 34-year-old woman with a dichorionic diamniotic twin pregnancy presents in spontaneous labor at 37 weeks gestation. At 8 a.m., the cervix is 4 centimeters dilated with intact membranes. At 12 o'clock, the cervix is 5 centimeters dilated with intact membranes. She is contracting 3 to 4 contractions in 10 minutes. So we are assessing her after 4 hours. She is less than 2 centimeters dilated. So we suspect delay. So the next step we'll do is ARM. Her contractions are adequate, so we'll go for an amniotomy.
Amniotomy, yeah.
Yeah, amniotomy is the answer, I think.
We have in the answer, yeah.
Perform amniotomy.
Yes, perform amniotomy.
Perform amniotomy, yeah.
There is the answer.
Why not reassess after 2 hours?
The correct answer.
No, as Dr. Fath has already said, like after amniotomy, we'll reassess in 2 hours. And if it is less than 1 centimeter, then
that's right.
Yeah, but first we perform an amniotomy. After 4 hours, we perform an amniotomy and then check reassess in 2 hours.
Yes, after amniotomy, always we check after 2 hours. Yeah.
In case the patient is not willing for amniotomy at that point, then we'll reassess her after 2 hours, and then we'll check for progress. Then we can also do an amniotomy at that time. So the answer will be perform amniotomy.
see, reassess after 2 hours. This patient is still in latent phase.
Not amniotomy. Yeah. So at first
Already
it's been
patient
reassessed.
already was getting good contraction. You need to reassess. You will not give her adding contraction for her. Am I right, Dr. Fatih?
As far as I remember, the rules of stepwise when we are suspected to delay of the dilatation progression, as you mentioned exactly, before we do amniotomy, at first we check, reassess when we suspected in the first step. We recheck after 2 hours the re-exam. If it still is delay and no changing of the dilatation or is just less than the optimum, then we do amniotomy. Yes, firstly we recheck in 2 hours.
The patient is still in latent phase.
In that the table, Dr.
Still,
in the table, Dr. Fat like clearly mentioned, like after 4 hours, the first next step we do is amniotomy.
No. This patient is still in latent phase, not active phase. No need to do amniotomy from now. Still, you are going for progression for her, and she had 3 to 4 contraction intense. This means she had good adequate contraction. Just you will observe. Maybe after 6 a.m. I think so. You can do for that if this question after 6 a.m. But this patient is still latent. Why you are in hurry up to do amniotomy for her?
4 centimeters.
Okay, we only suspect delay in first stage of labor, so we have to confirm it after reassessing or after 2 hours. And after 2 hours, if the dilatation is less than 1 centimeter, then we confirm it as a delay in first stage, and then we go for amniotomy later. Am I correct?
No, still
Dr.
I'm
Fat?
not convinced, because when I asked Dr. Fat the same thing, because like there was a suspect and there was a confirmed delay. Like after 4 centimeters after 4 hours less than 2 centimeters is a suspect, and then after 2 hours less than 1 centimeter is a confirmed. But in the chart, in the flow chart, he clearly mentioned like after 4 hours to reassess, and if it is less than 2 centimeters, do an amniotomy. And if after amniotomy 2 hours, then it's reassessed less than 1 centimeter, go in for a C-section. If you go back, and that's what it was. And I specifically asked him for that, because in the previous slides it was suspect and confirmed delay.
Yes, 2 cm in 4 hours, it is normal. Less than 2 cm is abnormal. But this patient, she had adequate contraction still.
Yeah, so
Reassess
adequate
after 2
contractions
hours.
in active labor, it is a suspected delay. And so Dr. Fat, can you please guide us for this?
Reassess after 4 hours.
Dr. Fat?
Okay, sorry. Okay, let me to clarify this. Okay, if you have suspected delay, if you do for 4 hour BV and you find this is less than 2 centimeters, okay, this is suspect delay. Agree with me? This is suspected delay. After 4 hours, you find the vaginal dilatation is less than 2 centimeters. Okay, you have 2 steps after to suspect, either to do or consider amniotomy or to do BV. You should do BV after 2 hours. This is mandatory to confirm the delay. And the amniotomy is a consider, not over amniotomy. You should consider amniotomy, so you should counsel the patient about the amniotomy if the membrane is intact. If the patient agree or not, you counsel the patient about this. Amniotomy can reduce the labor by 1 hour and can increase the contraction. So you should consider amniotomy if membrane intact. If you give option,
Sir, I have a question.
let me complete.
If in the choices instead of perform amniotomy,
Please let Dr. Fatih to clarify first.
Let me to just clarify this, okay? If you give option perform like the previous perform amniotomy or reassess, you should choose the reassess in 2 hours, because you should consider amniotomy, but first you should choose this reassess in 2 hours. So we'll give the 2 options. If you find the 2 options, you should first choose the reassess in 2 hours before consider an amniotomy. You got my point?
Dr. Fatih, my concern
Because
is this.
if I rupture the membrane, I need to reassess in 2 hours.
Yeah.
So it is
No,
really
this patient
spoiled.
had good contraction. Better to reassess first, then you do amniotomy.
Amniotomy, yes. You should first do reassess after 2 hours before amniotomy. If you give 2 options, if you didn't find the assess in 2 hours, you can choose the amniotomy. But if you give the 2 options, you should first choose the reassessment hours. Okay?
Yes, Dr. Fat. Thank you, doctor.
Oh, okay, good, clear.
The question, 2 questions, yeah. $34 and $35. We will share.
Can I ask? Can I do the questions 34 and 35, Mr. Fat?
You can read it, okay? And answer it, okay, please.
Yeah.
I will. The next question, 34, 35.
You have been asked to review a 35-year-old woman half an hour after spontaneous vaginal delivery of her first child because the membranes are ragged, although the placenta is complete. The uterus is well contracted, the lochia are normal, and all maternal observations are satisfactory. Can I see the options? IV oxytocin, cesarean section, fetal blood tamping, no additional intervention required. Umbilical artery open, reduce oxytocin, no additional intervention.
Yes, excellent. No additional, because all maternal observation are satisfactory. So no need for.
So no additional intervention. Option
Yes.
D is ideal.
Yes, you're right. Agree with you, because no additional intervention at this stage. This is D. Okay. 35 question.
35. A 35-year-old mother of 2 children presents in spontaneous labor at 39 weeks of gestation. She has 1 previous cesarean section for breech presentation, followed by a spontaneous vaginal delivery. At 12, the cervix is 7 centimeters dilated with a direct occipito anterior position with 3 in 10 strong contractions. At 4, the cervix is 7 centimeters dilated and the contraction. This is the same question we discussed.
Yes, yes. This is the same with this. Yes,
Cesarean
you're right.
section.
You're right.
Same question. Yeah.
Yes, this is the same question.
Mr. Fat, can you please
So,
the definition of secondary arrest? Like, can you tell the definition of a secondary arrest? You mentioned when you were explaining this that this is a secondary arrest.
yes, the answer here is
No further
no additional
dilatation.
intervention in this stage. Yes, okay. Question 36.
Question 36. The scenario, please, Dr. Fat.
Okay.
A junior trainee seeks your advice about a 20-year-old low-risk woman in spontaneous labor at 39 weeks gestation. Progress has been normal with intact membranes, but the woman's temperature is 38.2 degrees, 38.2. The fetal heart rate is 148 beats per minute on intermittent auscultation. Blood cultures, the FBC and midstream urine have been taken, and IV broad-spectrum antibiotics and paracetamol administered. It should be a continuous fetal monitoring.
Excellent. Yes, you should commence the CTG. Okay.
Yeah.
What is your answer here?
Commence CTG. Commence
Yes.
CTG.
Yes. It's a comment CTG. Yes. The last question.
The scenario, please. A low-risk 24-year-old woman is in spontaneous labor at 40 weeks gestation. She is 6 centimeters dilated with intact membranes. CTG was commenced because of the decelerations on intermittent auscultation. The CTG has been normal for 30 minutes. So we can go back to the. Can I see the options, Dr. Pat?
Yes.
Recommend, recommend intermittent auscultation.
Yes.
Discuss.
Intermittent auscultation. Yes, you are right. Yes, C.
Yeah. Recommend
So
intermittent.
she can go back to, this intermittent auscultation.
Yes, you are C. C is the right answer.
Yes.
Recommended intermittent auscultation.
Dr. Pat.
Yes.
38. The scenario, please. A healthy 20-year or 21-year-old woman is in spontaneous labor at 39 weeks. You're asked to see her at 10 because of fresh vaginal bleeding, estimated 250 milliliters. The maternal pulse is 86 beats per minute. BP is 135 by 72 millimeters mercury. The uterus is soft between the contractions and non-tender, and there are 5 to 6 contractions every 10 minutes. The CTG is normal. Vaginal examination shows the cervix to be 8 centimeters dilated with no forewaters, and there is a 100 ml clot in the vagina. The CTG is normal, and can I see the options?
5 to 6 contractions.
5 to 6 contractions, and the CTG continuous bleeding and decrease oxytocin in the optimal consulting. And then,
You need an intervention, everything.
no intervention.
I think yes, no need for intervention.
No intervention.
Yes, no need for. Yeah, we'll see this question. Yeah.
No need for any intervention.
No need for intervention. Yes. What about 39?
A healthy 20-year-old woman presents in spontaneous labor at 37 weeks of gestation in her second pregnancy. The first baby was delivered by C-section because of breech presentation. You have been asked to review the CTG. The baseline is 145 beats per minute with variability of more than 5 beats per minute, and there are atypical variable decelerations over 20 minutes. On vaginal examination, the cervix is 6 centimeters dilated. She has effective epidural analgesia. So there is a atypical variable deceleration over 20 minutes.
Atypical variable deceleration.
Yeah. So can I have a look at the options? Centimeters. Atypical.
Fetal scalp sampling, C.
Blood sampling.
Can reassess 2 hours also.
Sir, how about doing option C, fetal blood sampling?
Here, look for this for question.
Reassess in 2 hours. This is still nothing.
It's variable decelerations with concerned characteristics.
20 minutes.
20 minutes. So
what about the cesarean section option?
yes.
Agree with B?
Yes, it is because it is with
B.
yes. There is
Okay,
section
sir. B.
B.
Yes.
B. Yeah, cesarean section.
Yes, I think it is.
Yes, agree.
The correct answer.
B.
Yes, cesarean section. Yes. So, 38 is A, no need for intervention, and 39 is cesarean section.
Cesarean.
Rahmia, can you answer this question?
40. The scenario, Dr. Fat.
Yes, 40, question 40.
A 23-year-old primary gravida is admitted for induction of labor at 42 weeks. 3 hours after the vaginal prostaglandin administration, she complains of painful contractions every minute. CTG shows contractions 8 in 10 lasting 30 seconds. The fetal heart rate is 140 beats per minute with good variability and deep variable decelerations.
Hyperstimulation. This is hyperstimulation.
Hyperstimulation.
So we can remove the prostaglandin, increase oxygen, subcutaneous turbulence.
K will be the answer. Subcutaneous turbulence.
Agree with yeah.
Subcutaneous turbulence.
Yes, doctor.
Yes.
Yes.
Yes. Okay, thank you so much. Inshallah, the next Thursday, inshallah, we'll discuss about the management of labor, inshallah. Okay, thank you so much.
Thank you so much, sir. Thanks a lot. Very nice session.
Jazakallah, sir. Thank you so very much.
Thank you so much, sir.
Jazakallah, Jazakallah.
Dr. Fathi, it will be every Thursday sessions?
Yeah, every Thursday, inshallah, will be session part 2, inshallah.
From 7 to 1?
Part 2. Inshallah, see you in Thursday, inshallah.
Thank you, Dr. Fat. Thank you.
Thank you.
Yeah.